Good afternoon and welcome to Baptist Cardiac and Vascular Institute in beautiful Miami, Florida. I'm Dr. Jonathan Roberts. I'm an interventional cardiologist here at Baptist Cardiac and Vascular Institute, and we're so pleased that you're going to be with us for the next hour to learn about closing a small defect in the heart called a patent foramen ovale. I'd like to introduce my colleague, Dr. Ramon Quesada, who is an interventional cardiologist and who's going to be closing this defect. Ramon, tell us where you are in the cath lab and a little bit about your patient.
Yes, thank you, Jonathan. Good afternoon, everybody, or morning or evening, depending where you are. Welcome to Cardiac and Vascular Institute. This is our cath lab. It is not an operating room. This is an endovascular suite, meaning that we do procedures here based on imaging and not by incision. We have a lot of people here. My assistant, Claudia, Dr. Ralph Machado, Chief of Cardiac Anesthesia, in which being helping our team. I have our nurses, Natalia, Rosa, Paul, Mario, our echo technician, and our nurse anesthetist, Katia Ramirez. Welcome, everybody. This is a very interesting case of a procedure that we do in young and elderly patients also. It's a 29-year-old female who had 2 strokes, one recently, with no apparent cause. So all the neurological workup that was done on her, it was totally negative. The only source of this, possible source of these strokes is embolization coming from a little tunnel in the heart that Dr. Roberts will talk to you about. Jonathan?
Thanks, Ramon. I'd like to remind the viewers we'd like for you to participate, and if you have a question during the broadcast, if you look on your screen, there's an Ask a Question button, and you can click that and email us in a question so that you can participate. I'd like to go over the anatomy a little bit of the heart to give you a better understanding of what we're doing and why we're doing it. This is a graphic representation of the heart, and this is the right side of the heart, and this upper chamber is called the right atrium. This is the left side of the heart, and this upper chamber is called the left atrium. Now, when we're in our mother's uterus, in utero, there's a connection here between the right side of the heart and the left side of the heart, and this little tunnel here is called a patent foramen ovale that all of us have when we're in our mother's uterus. And the reason for that is that the baby inside the mother's uterus does not breathe, and so the blood does not go to the lungs. The mother's oxygenated blood goes from the right side to the left side of the heart, and then the left side pumps the blood to the rest of the baby's body. As soon as we're born, this PFO closes in most of us. Over the next 1 to 2 years, in 75% of us, this patent foramen ovale, or this tunnel, will close. In 25% of us, this patent foramen ovale will stay open for the rest of our life. So why does that even matter? Well, it matters because in some people, we may develop little clots inside of our legs and the valves. And if they come up and there's no connection, they go to the lungs and nothing happens. If this small clot comes up to the right side and can get across this patent foramen ovale into the left side, that can be a cause of a stroke because that small clot can then travel through the left side of the heart, get pumped up to the brain, and cause an injury in the brain, which is a stroke. And here's a diagrammatic representation of a small clot that comes through the right side, can get through that PFO, and then the left side pumps it up to the brain and causes a stroke. What I'd like to do now is to show you a video, our first video, that's going to show a graphic representation of a PFO and how the blood can go from one side of the heart. Here is the picture of what I've just showed you. And here's normally what happens. The blood, the darker, stays on the right side. The red blood's on the left side. Here's the PFO. You see a little bit of blood that can go from the right side of the heart to the left side of the heart. And if a small clot forms in our leg that we're going to show you right here, in the valves in our legs and the veins, there can be a little bit of sludging of flow. If we get a small clot, even the size of the head of a pin, if it travels up, as we're showing here, through the veins in our body, and then can cross that PFO, go up into the brain, that can cause a stroke. And that's the reason we're here today, so that we can close this PFO. Here is a representation of what Dr. Quesada is going to do. through a vein in the leg, insert a catheter or plastic tube, and go up into the heart and fix that PFO. Ramon, where are you now in the cath lab?
Okay, welcome back. So here we have two introducers, one in the right femoral vein, it's a big vein, and another one in the right femoral artery. There is a catheter that can you show the fluoro images, please? There is a catheter inside the heart, as you can see there, that is an ultrasound. And with that ultrasound, I'm looking at the heart. Can you show the ICE images, please? So there, Dr. Machado will tell you the chambers of the heart and where the defect is. Ralph, can you go ahead, please?
To label the chambers of the heart, right atrium, left atrium. This small membrane that you see is the interatrial septum. And I'd like you folks to keep your attention focused in the area designated by the arrow. That's the site of the PFO. Dr. Quesada is going to inject a small amount of agitated saline and in an attempt to demonstrate how bubbles may cross from the right atrium into the left atrium. In a similar manner, a small thrombus would cross, creating that stroke. Ramon?
So, yes, thank you, Ralph. So you can see here I have another catheter in the vein, and we're going to do what we call a bubble study. So I'm making little bubbles of agitated saline, and I'm going to inject this to see if they cross in from the right side to the left side of the heart. Can you please focus on the ice? You can see the injection here of the bubbles.
Need a more vigorous injection, Ramon.
We're going to need a more vigorous injection. So what we're going to do is I am going to get more fluids, and I'm going to pull this catheter out to do a good bubble study. Can you hold this thing for me here? Thank you. Give me the syringe. So we're going to get more bubbles. All right. Same procedure here. You can see it. And now we're going to do a real injection. You can see the amount of bubbles crossing from the right side to the left side. You see all these little bubbles? And that's why this patient had two strokes.
Show the clip.
So can you play it back so they can see how the bubbles go?
Did we have another clip where the bubble study was better, Debbie?
Yeah. We'll show you in a second. The first clip that we did. So anyway, also by Doppler, you can see. Focus on the eyes. Focus on the eyes, please. This is a study that we did just a few minutes ago, before we went live, to prove the points. You can see the bubbles coming from the right side of the heart and top, going into the inferior portion of this image, which is the left side of the heart, which is the left atrium, and proving that there is a communication between both sides. Ralph, you want to say anything? You want to say something there?
No. Again, the same way that these bubbles are going across, a small thrombus would go across, creating a stroke.
So the next part of the procedure is we need to put our catheter across that tunnel, so we can go ahead and advance our devices and close it. So before we show you that, let me just advance the catheter with a wire inside the right side of the heart and then across the tunnel. Okay, Rocky. All right. So you see, there's can you show the fluoroscopy images, please? So you see the catheter inside the heart and the right side. So I'm pulling back the catheter. You can see it right here. And I'm guiding myself by the ICE images and also the fluoroscopy images, and I cross through the hole into the left side of the heart. Now, we usually like to be in a place that we call the pulmonary vein, and we're going to make sure that we are there by our echo imaging. Can you show me if I'm there, please? I don't know if I'm there. Yes, I think I'm there. Put some color there. So So that way, the patient at this point we are already gave him anesthesia, is in the pulmonary vein or in the left atrial appendage.
Color off, please.
So we always stay very careful to where we position our wires, so we don't have any chances of having putting the wire in a place that we don't want to be. So we want to be in the left pulmonary vein.
I'm not seeing the veins real clearly, Keith.
Oh, yeah, I'm there right there.
Okay, there you go. Okay, you're good.
I'm good. So anyway, so we leave the wire there. Can you show me the fluoro, please?
That's nice.
We're going to leave the wire there, and we're going to pull the pull it out.
Q, you may be in the appendage there.
I know, I saw that.
Okay.
All right, so the next step is that we're going to show you the devices before we go back to the to Dr. Roberts, that will explain you how do we do this. Can the cameras come over here? So we have different catheters and that we use. First of all, we're going to measure the length of the tunnel that we're going to close. And for that, we use a balloon, which is here. And we'll advance this through the... we're going to exchange wires. We put an introducer there to put a big balloon through that, and then we'll see in a second. Can you put color in that image? Let me see if I'm at the appendage on the left atrial. Appendage? All right. Can I have the multipurpose? We're going to reposition our wire in another place to make the procedure safer. It's important, safety of the essence of all these procedures. If there's any question from you just click through the internet. We'll be more than happy to answer and discuss it. So I'm doing the same thing. I'm in the left side of the heart. Fluoroscopy, please. Yes.
Questions. Let me just read some, and
yeah.
If you need to work or want to talk, just interrupt, please. A great question. I'm 70 years old and had a stroke last year. Mm-hmm. I have diabetes and high blood pressure. Should I ask my doctor to look for a PFO? That's a great question.
It's a great question.
My answer would be if you have reasons to have a stroke, high blood pressure, diabetes, and especially if they're uncontrolled, that's reason enough to have a stroke, especially in someone who's not young like this patient, 28 or 29 years old. And I would say no, you do not need to. It's the cryptogenic stroke that Ramon was talking about. That means a stroke of unknown cause, somebody that has no reason, no diabetes, no hypertension, as in this young patient. That's the ones that it's imperative, I think, to look for a PFO. What do you think, Ramon?
I totally agree with you. I think, all these patients that we are closing, they go through a very thorough neurological workup. It means that the neurologists have evaluated and looked for all possible causes of stroke. And the only possible cause was this, and it was diagnosed. So in a patient like the ones that you asked the question, a 70-year-old patient with diabetes, hypertension, there's other reasons why this patient could have a stroke.
And Ramon, what are some of those other tests that you get for your patients that, if they came in with a stroke, that would be ordered to look for a cause of the stroke?
Well, the first thing that we do is first set the etiology of the stroke. Is it stroke embolic, thrombotic, and hemorrhagic? So they do MRIs and CTs of the brain. Mm-hmm. We do carotid studies because the carotids in these elderly patients are a source of embolization and also arrhythmias in the heart. arrhythmias in the heart, like atrial fibrillation with irregularities of the heart. See, and you can have bad ventricles also after your heart attack. Those are source of possible emboli. So we do a very thorough workup. As a matter of fact, we will not close a patent for amenovale unless the patient has full evaluation by neurology and also a full evaluation of her hematological profile, making sure that there's nothing else that could explain this.
I think it's so important what you just said. If there's another cause of a stroke, someone has an irregular heart rhythm that you mentioned, atrial fibrillation, if you put a PFO closure device in, you're not treating the cause of the stroke. So as Dr. Quesada mentioned, you have to have a complete evaluation for the stroke that includes your neurologist, a cardiologist, and I want to stress that. I think it's important. Okay. Should we take another question? Or Ramon, do you have, where are you in the procedure?
We are right now advancing a balloon across the device.
Okay.
Across the, not the device, across the defect in the septum. As you can see it here, show the image in the fluoroscopy. You can see that catheter go with two markers there. That is a balloon. And we're going to inflate the balloon slowly to see the defect in the middle. You can see it there.
And what's the purpose of inflating the balloon? What are you looking for?
We're looking for measuring, most than measuring the size of the defect, looking at the anatomy of the tunnel. The anatomy of the tunnel is important because sometimes we have to select the proper technique and the proper device to close this defect. So right now we are measuring this. We took a picture. We're measuring the size. And this is a small tunnel, as you can see here. A straight tunnel, a straight channel with no significant problems. Can you? Some tunnels can be very tortuous and long, and that oblige us to do take different approaches and different techniques. Sometimes we have to go through the septum with a needle and see if the tunnel is too long, and close it from both sides. So it's the technical aspects that we have to make sure. So we learn a lot about the anatomy of the tunnel by doing this balloon sizing. Okay, we already saw that, and we're going to pull back with our balloon. And Ralph, do you want to comment on the echo that we saw with the balloon?
Well, what Dr. Quesada has done is he's inflated the balloon to the point where the color flow stops. And once the flow stops, that balloon is filling the tunnel, giving us clear images of what that tunnel really looks like, how wide it is, how long it is, and we're able to judge what type of device as well as how large a device needs to be placed.
So now we know, we have an idea. We think that the device is about 1.1 millimeters or 10 millimeters. And we're going to choose different devices to close it. Let me show you. Can you focus here for a second?
Ramon, you said about 10 millimeters. How many inches is that for our viewers that don't understand millimeters?
Half inch.
Half inch.
Half inch.
Half inch. So this is a catheter that we call it the delivery sheath. So our device is going to go through this catheter, and we're going to mount it. And this is the device that we're going to use. It's called the cribiform device. Dr. Roberts will show you in a minute how this works in the cartoons. And we attach this umbrella type of device to the catheter that actually going to deliver it. And we mount it. I tend to drop this thing, so anyway. But I did it right this time. So the device is mounted.
Can they do a close-up of the device, and then, Ramon, can you pull it apart to see the two discs?
Yes.
Is that a possibility?
Can you show it? It's a close view. Have you seen a close view of this? So I'm pulling it apart right now. You see it?
Perfect. I see the two discs and a little waste in between the two discs. Okay, so that's the closure device.
So I mounted. Let me do it again. You want me to do it again?
No. We see it. Do your normal procedure.
Okay. So now we're going to mount the device inside the catheter, and we do it under water, so there's no bubbles there, because bubbles also can be a source of embolic events into the brain. can you focus on this for a second, please? So we're putting the device inside the catheter to deliver it, and then we flush it. Very good. So we're flushing this underwater to get rid of all the bubbles that you can see here. So the bubbles are going out. There's micro bubbles, big bubbles, little bubbles. So we take our time. This is a very important phase of the whole procedure. You want to make sure that it's clean, there is nothing, there is no bubbles inside the catheter. Once we have that, the catheter is ready to be placed into the delivery sheath. Okay, so we leave it up for a little bit here, and we're going to go and now place the delivery sheath inside across the atrium.
Ramon, while you're doing the delivery sheath, I want them to stay on you and watch. Go ahead.
Okay.
A great question here from a viewer. Aside from stroke, what other symptoms would a person experience if they had a PFO? And does a PFO cause a heart murmur?
That's a great question.
It is a great question. There's no heart murmur. We do not hear, if you have a murmur, it's not from a PFO. And Ramon, do you want to talk, are there any other symptoms other than having a stroke?
Yes. You know, as a matter of fact, we have seen everything from a PFO. Remember, this emboli is very common to go into the brain because the arteries of the brain are the straight shot from the heart. But it actually can go anywhere in the body. It can go to the legs, can go to the kidneys, can go everywhere. You even can have paradoxical embolization into the arteries of the heart and have a heart attack. And that's uncommon, but it's happening. So any place that the arterial circulation goes can be a source of an embolization from this defect.
Great answer. Where are you now? Do you have the delivery sheath in, or are you placing it in?
I am placing it in. I have the wire across. Can you focus right now on my hands, please? Right here. Show my hands for a second. We are advancing the sheath inside the femoral vein, and I'm going to show you, as Dr. Roberts showed you in a cartoon, how this happens. So this is the catheter, and it's going up to the heart.
And you have a guide wire already in the left
Right.
side of the heart coming out in the vein in the leg. Is that correct?
Yes.
Good. And you're just advancing that sheath.
Are you seeing the fluoroscopy?
We're seeing it great.
So, okay, hold the wire, then pull down. Let me do this. So let me show you this. Hold the wire, hold the wire, hold the wire. Now I am getting inside the heart. I'm crossing the defect. And the wire came back a little bit. Thank you.
You lost image, Ramon.
I lost image. See the fluoroscopy, please? I am there. So the delivery sheath is inside the heart. And now what we're going to do is we're going to leave the delivery sheath inside the left atrium, as we show in the cartoons, and we're going to pull the introducer, leaving the wire for a second. Do it.
For those of you who may just be joining us, welcome to Baptist Cardiac and Vascular Institute. If you have questions, there's a little button you can press on your screen. Just ask a question. We've gotten some great questions from our viewers.
So now that we'll put in the wire, and we're going to clear the catheter of any bubbles that's possible there, so we don't want any embolization. That's what I'm doing right now. Can you focus in my hands, please? That's exactly what I'm doing. And we're going to be ready to deliver the device going inside the catheter. Look at my hands, please. Okay, thank you very much. Flush. So this is the device mounted in his catheter, which I'm going to advance.
Ramon, before you deploy,
I'm going to stop.
Good. We have these great graphics. I just want to go over.
I'm just going to show you where the catheter is at the tip, and then right there, you can go and do your thing.
Good. Let me show everybody a little graphic representation of what Dr. Quesada has just done so you have a good understanding. Here again is this picture of the heart. And what Dr. Quesada has done is he's placed this plastic hollow, we call it a delivery sheath, across the patent foraminal valley, we see right here, into the left atrium. And this is just a blow-up view. It's a hollow tube. And through this hollow tube is where the delivery is going to take place of the closure device. Okay? So that's what...
We can see that on echocardiographically as well, Jonathan, right now.
Great. I'd love to see that. Why don't we show a clip? We have our second clip that will show a video animation of closure of the device. So here showing the catheter, what Dr. Quesada has just done. The catheter is across the interatrial septum, across the PFO. Here's one disc being deployed in the left atrium. And then Dr. Quesada will pull that tense against the left atrium, expand the disc in the right atrium, unscrew the device, and it stays there, and it seals off the PFO.
So, okay, so Ralph, you want to show him on please show the ice image, please.
Remember before, this was the left atrium, right atrium on top. Here's the catheter going through the PFO into the left side of the heart, and through that catheter, Dr. Quesada will deploy his device. Again, just keep your attention focused in the area of attention where the arrow points.
So let's go through the live for a second. So now I'm advancing the device and pulling the disc. As you can see here, can you show the? This is the disc in the left atrium, and now show the disc in the ultrasound, please. You can see perfectly the disc and the ultras and the IVUS and the ice. And now we're going to pull down to the septum to deploy the other side of the device. So I see it coming down to the septum. You see it right there. Opposing the left side of the device against the tunnel in the left atrium. And I'm going to start pulling the right disc of the device like so. And now I capture the septum on both sides of the device. You can see that right there. And then we take a break. We make sure that everything is the way we like it before releasing the device.
Ramon, while you're taking a break and watching that device, you're going to pull it.
Go to a regular image,
We've had
please.
some great questions. I just want to ask you some of your thoughts. Question, would you say that the PFO is benign in most people who have it?
Absolutely. 20%, 50 to 20% of adult population have a patent foramen valley and they never have a symptom in their lives. It's a very few percentage of patients of population that can have this event. So having a PFO is not a disease. It's a variant, I can say, and we only treat them when it's really necessary. Let's say you are a pilot or you are a professional diver, a marine biologist, and you're going to go into deep in the ocean. So, and that's regard if you have a patent foramen valley, the risk of having embolization are higher, and then those are situations in which we will close it. But other than that, you have to have evidence of a pathological event. That's what we call it.
Yeah, I think that's really important to stress that, again, in some series, up to 25% of patients will have a PFO. So that means 70 or 80 million Americans are walking around with a PFO. And most people, and the vast majority, it's totally benign. So it's something you don't need to seek out and worry about.
That's great.
All right. You want another question, or you want to keep going there, Ramon?
Okay, well, another question would be good.
Okay, this is a great question. I've heard of a PFO with an atrial septal aneurysm. What does that mean? Is this worse than a regular PFO?
Well, you know, that is very important question. I think that's an incredible question because really atrial septal aneurysm that means that the septum is very floppy. Like in this particular patient, maybe we didn't say that at the beginning. This patient have a very floppy septum. It's like an aneurysm, meaning that the septum is not straight. It moves with the movements of the heart, inside the left atrium and then back into the right atrium. The association of an atrial septal aneurysm or a hypermotile septum is considered that in the presence of patent foramen valley increase the chances of having a shunt and embolization. But the atrial septum aneurysm by itself without any evidence of communication is not really associated with pathology at this point.
I'd like to just comment. Usually when we think of an aneurysm, especially in the brain or in the aorta, we're talking about a swelling of a blood vessel that's abnormally dilating. And really an atrial septal aneurysm is not that. We're not talking about that. And I wish it was never called an aneurysm, but was called a floppy septum, just what you said. And it's not a vessel that's going to burst open. That's a little bit of a lot of our patients, when they hear aneurysm, there's a lot of fear that something's going to break. Any comments about that, Ramon?
No, I totally agree with you.
Yeah.
I think it's a misname. It's a misname of the. It's not an aneurysm. It's a floppy septum. It
Great.
means the septum moves too much, but it's nothing going to happen if there's no communication.
One more question. This is a really good question. What are the risks associated with this procedure?
Well, unfortunately, this is a very safe procedure, but it's an invasive procedure. Any invasive procedure carries the risk of bleeding, even perforation of the heart, because we're putting tubes and catheters inside the heart with wires. You saw me moving the wire from one position to the next position, and I mentioned the word safety because it was in a place that is called left atrial appendage. That is a very thin structure that is very easy to perforate. So you have to be very compulsive and very careful when you're doing and manipulating wires and catheters inside the heart. So even though it's a low-risk procedure, it's considered to have possible complications. That's why when we do these procedures, you have to make sure that the patient needs the procedure to be done. So indication is very important. So this is not, that's why we don't close everybody. Number one, this is an invasive procedure and it needs the respect of being an invasive procedure.
One more question, then I want to see you release that disc. Somebody asked, is there any other therapy for a patient with a stroke with a PFO, and is it as good as a closure device?
That is a very good question. Yes, there is other therapies available for patients with a stroke, and one is the use of antiplatelet therapy and the use of anticoagulation with Coumadin. That is as compatible as using closure. The difference is, and there's a study that was just presented a year ago, we were part of the study called the closure trial, in which we compare patients with several TIAs or strokes, more than one stroke, to continue on medical therapy with Coumadin or antiplatelet therapy with aspirin, Coumadin or aspirin, versus closing the defect. And the surprise was that both groups did equally. The incidence of second strokes in up to 2 years was very similar. So there was no advantage, but that doesn't mean that the study was negative. What it means is that medical therapy is very efficacious, but you have to continue with the medical therapy. So patients who are already on Coumadin, who are young patients, like this patient, 29 years old, if we don't close this defect, you already have 2 strokes, she needs to be on anticoagulation for the rest of her life. And that is really what the difference is the choice. You close it because otherwise you might have to be on anticoagulator for the rest of your life, which is a very good option, by the way. That's the way it was done. In the past, before we had the percutaneous approach, and patients have recurrent strokes or embolization because of PFO, the surgical option was done. Patients were operated because of that. So that's a little extreme today, but it was done. So we have to put the things into balance and individualize for each patient in particular.
That's a great answer. And the closure trial that you're talking about, it really has made it a little bit either easier or more difficult when we talk to our patients. As Ramon, you said, the 2-year follow-up of these patients randomized to medical therapy or closure with a device, the recurrent stroke rate was very low and about the same in both. And this is an area in medicine we don't have a 100% answer all the time. And the patients in this study, Ramon, you can address this if you'd like, did not have to have brain imaging showing a stroke or showing something that happened in the brain. And that's certainly not the patient that you're closing right now, someone that's had past strokes and comes in with a present stroke. So I think we need to do a lot more research. There's 2 more trials going on comparing device closure with medical therapy. And this is a great area that we need to explore more. And I'm really glad that here at BCVI, Baptist Cardiac and Vascular Institute, that we're involved in this to try to help further the science of strokes and treating PFOs.
I think, Jonathan, that is a very, very important, and you mentioned it, is that in reality, and as an investigator in the trial, most of the patients who were referred for us for the trial, we couldn't even randomize. It took us 8 years to finish the study. And the reason was because patients who had already serious events, they didn't want to be randomized. They wanted the defect to be closed. So at the end, we end up randomizing patients that were probably low risk. And the other thing, there was no really strict documentation of a neurological event, which means by MRIs or different tests proving that there was a real event. It was a clinical interpretation of a transient ischemic event, which is very subjective. In our own practice today, we really don't close defects by our own clinical judgment. These patients are referred after a very thorough neurological workup, and it's really the neurologists who tell us this patient needs to be closed, and then we as an interventional cardiologist go ahead and make the assessment and closing if it's suitable for closure. But in reality, the indications is really after a very, very thorough neurological workup and individualize every patient by itself. The patient has a high risk because there is an open, like this patient. This patient had a floppy septum. She had a wide open patent ovale, foramen ovale. The bubbles crossed very easily from one side to the other side. She already had 2 events, and she's 29 years old. So what are you going to do?
That's the patient. What we're going to do is what you're doing today, is closing the PFO, the defect there. Ramon, I want to make sure time-wise we have enough time. Can you go ahead and let's move along and deliver the device? Show us how stable it is by pushing and pulling, and then show us the delivery of the device.
Okay, can you show, please, the eyes imaging? So you can see here the image in the eyes. You have it's a disc. You have 2 discs. One side on the left side where the arrow is on the right side, and this is the arrow in the left side, and now the other disc is in the right side, and in the middle of that is the septum, and you see the floppy septum moving on your left, and you see the tunnel, and now we need to test that the device will stay there. In otherwise, I don't want to release this device and it will fly around the heart somewhere else. So we make sure that the device is stable. So for that, we do what we call the tugging maneuver, which is we pull back and forth, making sure, you can see in the fluoroscopy that I'm pulling the device back and forth, making sure that it's stable, and it is stable. So I'm very comfortable that the device is in good position. Can you put color flow there and see if there is any flow around? Now remember, this device is not released, so there's some tension on the septum, and you can see flow inside the device. So I am happy that it's not compromising any structure, and now we're ready to release it. You can see the fluoro imaging, please.
Ramon, before
Yes,
you
sir.
release it, let's watch that video one more time.
Yes,
That
go ahead.
People will understand really in their mind what you're doing. So again, this is showing the catheter going across the PFO, and here's the release of the left atrial disc. And as you saw Dr. Quesada do, you pull it against the inner atrial septum, like that. And then we saw the second disc, the right atrial disc, deployed. And then right now, what Dr. Quesada is going to do is unscrew that device and release it so that it's closing the PFO. Okay, Ramon.
All right, let's go to the fluoro for a second. You see it in fluoro, I'm putting Cena there, and now I'm turning this. You can show my hands if you wanted to. And we're going to release it. The device is released. And now we're going to go back to, let's go back to the eyes imaging, please.
And you've lost imaging a little bit on the ice right now.
Yes, I'm going to improve the image on the eyes. All right. You want to comment, Rob?
Here you see the device released in its final position. It acquires a better position once it's released from the catheter, with the left atrial disc and the right atrial disc in an appropriate place, closing the PFO channel.
So now we're going to do a bubble study again. The other thing that we always do is we check around, make sure that we're not compromising any structure of the heart that we already did before we release it. But anyway, we always do it twice to make sure that everything is fine. I'm very happy with the results. It's a spectacular result, really is. And now we're going to repeat a bubble study. You know,
Ramon, while you're getting that ready, here's a question. Does this procedure carry a risk of stroke itself?
Absolutely. There's no question about it. We are having catheters inside the heart, and you can form clots on both sides of the device. And that's what these patients are with blood thinners. We put them on heparin. Heparin is a intravenous blood thinner through the device, and we test the blood to make sure that the patient is well anticoagulated through the procedure.
And is there someone you would not close a PFO that you thought that was a cause of their stroke because of a clot somewhere?
If the patient had a clot in the left ventricle or had a clot on the left atrial appendage, and then it's a difficult position because you're going to be manipulating the device inside the left side of the heart, and then you don't know if it's the left atrial appendage with a clot inside their heart or the left ventricle, the apex of the heart with a clot and not the PFO. So you have to be certain that this is the real reason why we are here. So I'm going to do another bubble study. Please look at the eyes.
If I could make a comment, sometimes, most of the time, this bubble study is negative. That is, bubbles no longer cross. But it isn't necessarily the case in all patients. Oftentimes it takes 6 weeks for the device itself to epithelialize and seal in a more permanent way.
I totally agree with you. I think, you know, even if we see a couple of bubbles crossing through, I'm not worried about it because, as you mentioned, this is going to close. But it's always nice to see that there's no bubbles going through. So let's see it now. Can you show the eyes imaging, please? You can see that compared to what we had before, there is no bubbles going through. So this is a perfect closure, great result, and we are happy for the patient.
Display that loop and the old loop.
Ramon, if you saw
The
bubbles
original
here still, would that concern you, and how would you follow this up?
Well, it wouldn't concern me really because, as you know, because the texture of the device, you could expect to see bubbles immediately afterwards. And we will follow this patient with a transthoracic echo and bubble study, repeat bubble study in a month and 3 months, and to make sure that everything is covered and authorized. So, the other thing that we do is that we keep these patients on antiplatelet therapy, aspirin and Plavix, which is another antiplatelet drug, for 3 months until we're certain. It varies, 3 to 6 months, depends. In the study, we were mandated to keep him on aspirin for forever and Plavix up to 3 months, until we're sure that the whole septum is endothelialized or covered with tissue.
Another question I think is great. Is general anesthesia used for the procedure? And can you explain what the recovery is like and how long you're in the hospital after the procedure?
This patient is sedated, is what we call conscious sedation. We make it comfortable, but she's not under general anesthesia. Babies, they use general anesthesia because obviously, and if I were to use transesophageal ultrasonography, we'll put a catheter in the esophagus. Those patients, we put them under anesthesia, but we use mostly for this type of the procedure intracardiac ultrasound. As you can see here, can you show my hands for a second, please? This catheter here is the ultrasound, and this catheter is put under the heart, so I don't need to do any anesthesia. We pull the catheters out as soon as we finish, and these patients stay in the hospital for 23 hours, and they go home. It's an outpatient procedure, basically.
So they go home with a Band-Aid and the groin where you made the puncture site, is that correct?
Absolutely.
Yes.
Correct.
And they're up walking around several hours after the procedure?
They get up after 4 hours after the procedure.
And what restrictions do they have after they go home?
Well, the important thing is that they should not go into heavy-duty sports because the groin is going to be a little bit tender, and they can have a hematoma. Other than that, they're not restricted. I don't let them. Well, there is restriction if they do like diving, any sport like that. We would like to stay away from that for at least 3 months until we're certain that everything is closed.
And again, any special medicines that they go home on?
They go home only on aspirin and Plavix, and Plavix for a short term, then a baby aspirin indefinitely, and antibiotic prophylaxis. What does that mean? It means that you have a device inside the heart. So if you go to the dentist and have a dental work for the next 6 months, until we are certain that this is covered by tissue to prevent the risk of infection, and I haven't seen one, thank God, yet, we gave him antibiotic prophylaxis for dental procedures or colonoscopies, any procedure that is not considered to be a clean procedure.
And if the patient came in on Coumadin, as many of our patients do that have had a stroke, we find a PFO, what do you do then?
We take them off Coumadin and they go off on aspirin Plavix, unless there's an indication for Coumadin for other reason. Let's say the patient has atrial fibrillation. Then this patient probably should be on Coumadin, and this patient will continue on Coumadin. We put him back on Coumadin in a baby aspirin.
Great.
A quick comment regarding the anesthesia, Ramon. These patients are under a deep sedation, and it's a type of anesthesia similar to what one might receive for a colonoscopy, for example, where you're asleep, you don't remember any part of the procedure usually, but awake and really ready to go in a relatively short order.
Thank you, Rob. I should have let you answer that question about anesthesia first.
Yeah. Another question here, Ramon. What is the expected lifetime of this device? Does this cure the PFO forever? Do you need to replace the device in the future?
No. First of all, this device is going to be part of your body indefinite for the rest of your life. Now, saying that, there is 2 new devices that are bioabsorbable. They're not approved in the United States. They're investigational. One is made out of pig intestinal mucosa that is approved for plastic surgery. They use it in burn patients. So instead of having the disc, they have this cover that is biodegradable. And there's another device that's totally experimental, also that is completely 100% bioabsorbable. So the device will disappear with time in approximately 6 months to a year. But those are not approved. They're far away from being in clinical trials in the U.S. And the other question, the other part of the question was, to replace it. No, they're not going to be replaced. Sometimes what happens is that you can miss another defect. Well, you shouldn't, but occasionally it could happen. And then you have to come back and enclose it with a second device. But that is rare, and about 90% of the in the closure trial, using not this device, other device, there was 85% of closure rate, less than 90%. What does that mean? It means that there was a lot of patients, about 10% of patients, that still have mini shunts after on follow-up. That is very specific to the device that was used, but I think with the new generation of new devices, that's very rare.
Well, let me ask you a question, and this is going to be a little bit, it's our real day-to-day life. A 55-year-old hypertensive diabetic has a small stroke, recovers thankfully, and in the workup is found to have a PFO, and his neurologist tells him, don't worry about that. Let's control your blood pressure, your diabetes, and we're going to put you on aspirin. What are your thoughts about that?
Well, you know, there were some, age was not, it didn't make a difference. It's as common in young patients as in elderly patients. But if the workup was completely negative and it's an insignificant PFO, I will treat it with medical therapy. There's nothing wrong with medical therapy. It's really, until we have further data, I think we're obliged to consider medical therapy also as the first option.
I think that's a great answer, that we're in a time period where we're not certain always what the right answer is. And I think there's 2 good therapies, medical therapy, device closure. This patient, though, that you showed us is just a classic patient that I would close the PFO, a young patient that's had prior strokes and present stroke, and are they going to stay on Coumadin for another 50 years? I agree with you. This is the patient that we should close the PFO. the one that you have on the table.
Absolutely.
Today.
I think this is really that's why we want to show this, because there is a lot of information in the press about all these things, and really, you know, doctors try to do the best for their patients, and every patient needs to be individualized. Treatments cannot be generalized. So sometimes too much information is not so good.
Yeah.
So if you have a problem and you have a question, it's better to you discuss it with your doctor, because he will or she will look what is best for you, and that's what we try to do.
Good. Another good question: can this procedure be done through the arm, or does the catheter need to go through the groin?
That's a very good question.
We have some smart people out in the audience there.
Right, I know. Most of the time, this procedure in particular is done through the groin. It's easier. Now, saying that, we have done this procedure when there's no access from the groin because there's problems in the venous system, through the neck, a vein in the neck. But that's unusual. From the arm, even though there's a couple of cases described in the literature, that's not the usual and the standard of not only that, you have to use a really large sheath, and if the risk is forgettable. The risk is too small.
Yeah, I think what the viewer may have been thinking about, because there's been a lot in the press recently, and the Miami Herald, is that we're doing cardiac catheterization in the artery to go up to the coronary arteries through the radial artery,
right,
which is in the wrist, and that's through an artery. And to close the PFO, we have to go through a vein, and we just don't have the same access in the wrist that we do for a vein as we do in the groin or in the neck, as you mentioned.
Absolutely. It's a totally different procedure.
Another good question here: will I feel the device once it is in place?
No, you will not feel the device. But saying that, because it's a device, like it's a foreign body in your heart, in the first few weeks, there's about 5% incidence that you can have palpitations, extra beats originated in the septum, in the atrium, because you have the device. But it's all usually transient and will go away, but no pain or anything like that.
Yeah, I think that's an important answer. Really, you can't feel it, and except for the transient atrial, these extra heartbeats, it's amazing.
It's amazing. You go back to your normal life, and most important, you feel comfortable that you're not going to have other problems. Okay. You know, it's interesting. Nobody asked the question about migraines, and
that was the next question. I have it right here.
Okay.
The patient said, "I've heard that PFO closure can cure migraines. Is that true?"
Well, this is a very important question, because in reality, there is an association. It's being an association between migraines and PFO. But we are interventional cardiologists. First of all, we don't know the etiology of the migraine headaches. And, you know, but there's a lot of saying. There's a theory that is microembolizations or vasoactive substances that are not inactivated in the lungs that go into the brain. But let me tell you some facts. The only study that's been randomized, it was a European study. It showed no difference in migraines. Even though the incidence of migraine attacks was lower, the study was considered negative. Now, on the other hand, all this thing with migraine started because all of us who are doing PFO closure, and in our own series, more than 400 patients who had PFO closure for strokes or really embolization, 30% of those patients have migraine headaches associated. And when we follow these patients, this is in our own series. This is not randomized trial. This is only observational. Close to 90% of those patients, the migraines went away. And because of that, in that same experience, it was repeated in multiple sites or operators doing these procedures, the whole theory of the migraines and PFO closure came about. But in reality, we don't have any proof of that. And in the era of evidence-based medicine, we have to prove effectiveness of therapy before we can just say, okay, let's close it. So we don't close patients for migraine. We close patients like these patients for stroke. I don't know. What do you think, Jonathan?
Ron, I agree with what you say. I think there's going to be a segment of patients with migraines that if we close the PFO, it will make them get better, because patients that you and I have closed, some of them say it's just incredible. They don't care that they're not going to have a stroke. They love it that they don't have a migraine. We also have some patients that I close their PFO and I see them in follow-up and now they have headaches, and that's the rare patient. I think there's so much we need to know. We need to continue the research that we're doing here at BCVI and that's being done throughout the world so we can figure out who those patients are that we could help. We're just about out of time, and I want to remind our viewers that if you missed part of this, if you came in late, or if you'd like to watch it again, it will be available at baptisthealth.net, or you can go on orlive.com and you can find the site and view it again for your viewing pleasure and to learn more about this. I'd like to thank Dr. Rafael Machado of anesthesia who joined us, of course Dr. Ramon Casana, and thank his patient who agreed to do this, and thank all of you as viewers for coming and watching. We hope that you've learned something. We hope that you've enjoyed the presentation. I think we have time for one more question or comment. Ramon, anything else that you want to say to the viewers about PFO closure and about the patient that you just did?
First of all, I want to thank everybody for being with us for an hour. It's been really a pleasure. We're very passionate about our work and what we do here at BCVI. And I want to thank my team for being with us late today doing this procedure. And it really is all about our patients. It really is all about doing things that will help them to have a normal life. And I encourage you to talk to your doctors if you have any problem. And what you see in the press is most of the time is not the actual facts. So get the right information from your doctors. And I want to thank you again for being with us. I want to thank my team, and have a nice evening, morning, or afternoon, wherever you are. Thank you.
Good. Thanks again for joining us here at Baptist Cardiac and Vascular Institute. Again, if you missed this or want to view it again, we encourage you to go to baptisthealth.net or to orlive.com, and you can find the on-demand button to watch this again. Any other final questions that we have that we can fit in here? And do we have anything there? We have about 1 more minute. Oh, this is a good one. Why does the foramen ovale stay open in some adults? Is it genetics or just something developmental? And why does it close in others? Ramon, anything?
Yeah, that's a very good question. That's, because it's the difference of pressure. It's a tunnel, it's not a hole. First of all, it's a tunnel. So when you're born, you take the first breath, the pressures in the right side of the heart drop. So the tunnel seal. But in about 15-20% of the normal population, this can remain patent, meaning that if the pressure on the right side of the heart increase, it can open spontaneously.
Okay, Ramon, I'm sorry to interrupt. I've got the signal here that we have to wrap it up.
Okay.
Thanks everybody for viewing. We hope you enjoyed this. We hope you learned something. And all of us from here at Baptist Cardiac and Vascular Institute, we thank you for joining us today. Have a good afternoon.
Thank you very much. Bye-bye. All right.